Thank you, Phyllis, so much for that introduction, and thank you to HDSA for inviting me to speak. It's wonderful how, as an organization, HDSA has had such constant recognition of the importance of mental health symptoms and treatment, and we really appreciate this. I, as a psychiatrist in particular, really appreciate this. So this is our notice that HDSA wants you to consult with your own physician. So I'll be talking a lot about different medications. I can certainly answer questions in general about medications. What I can't do is tell you how much of what you should take for your specific issue, but hopefully I'll give you some talking points to take back to your own clinicians if you have questions about what you or your loved one is taking for mental health symptoms. These are my disclosures. These are general advisory positions that I have with different companies about ongoing studies for HD. The one here that's mental health specific is the Azavan one. I am working with them on a compound to treat irritability and aggression in HD. I won't be talking about that in this presentation, but that is the one potential conflict that I have that's quite direct. So I'm going to be talking about how to think about mental health symptoms in Huntington's disease, specifically what to tell your clinician. So I think one of the big issues we run into is that people have these symptoms as part of HD. They may not know how to describe them when they go into the doctor's office. Sometimes the clinicians are not specialists in mental health. They may not know what these symptoms are. So to kind of help bridge that gap and give you the language to talk about these symptoms with your providers, I'll talk about some specific mental health symptoms and medications. As you all know, there are so many different mental health symptoms in HD that we don't have time to get to all of them today. And then at the end, I'll do just a little bit for care partners in thinking about your own mental health as you care for somebody with HD. So you can see pretty much any mental health symptom in Huntington's disease that you see in the general population, right? People are pretty much susceptible to any mental health symptom. There are some, because of the biology of HD and the way it affects the brain, that seem to be much more common in Huntington's disease. So there are some that do seem to be very much related to the biology of the brain. On the other hand, if you're somebody from an HD family and you don't know your gene status, just because you have a mental health symptom does not mean you have HD. These things are really not specific for HD. So the good news is if you have a mental health symptom, go out there and get it treated. It doesn't mean that you necessarily have HD. If you have HD, of course, you want to get treatment because it will make the disease a bit easier for you and for your family members to manage. As many of you probably know, the mental health and behavioral symptoms are some of the most distressing parts of Huntington's disease. They lead to hospitalizations, emergency room visits, and they're one of the main reasons that people get placed in nursing home and other long-term care settings. So that's why it's so important to understand what these symptoms are, be able to identify them, and be able to get treatment where it's available. Treatment really can improve your overall quality of life with HD, and it can make it easier for your family to care for you and perhaps keep you at home longer if these symptoms can be managed better. So this is what I'm going to talk about today specifically. I'm going to focus on some of the more common symptoms. So mood, including depression and mania, anxiety, psychotic disorders, so delusions and hallucinations, irritability and aggression, apathy, which is trouble with motivation. The ones here in parentheses are really interesting, and I'm happy to answer questions about them at the end, but I won't have time to get to them today. So just a little bit of data, since I do research in addition to my clinical work in HD. This is a fabulous study that was sponsored by the Huntington Study Group. It's called My HD Story, and it's completely online. So it's research that can be done completely from the home. We had over 600 people with HD who went online and participated in this study. And as part of the study, we asked them to say, what's the thing that bothers you the most about your HD? What's the one thing that bothers you the most? And when we got the answers and looked at them, probably not so surprising to those of you in this audience, but many people in neurology were surprised. The big blue circle there, the most common, were non-motor symptoms, and these were mostly psychiatric symptoms. Some memory and concentration problems, but mostly psychiatric symptoms. So by patients' own report, in their own words, non-motor symptoms are really the most common symptoms in Huntington's disease. There were, of course, people who reported motor symptoms. That's the yellow circle there. Some people actually reported both. So they might say, I have depression because I have movements and it makes it hard to do things. So then they might get counted as both. There were some people, and that's that big sort of purplish circle there, who said they had no symptoms that bothered them. So they had a diagnosis of HD, but nothing bothered them. So this is some fantastic research that we were able to do online. It is published now in the Journal of Huntington's Disease. And My HD Story as a platform continues on. So if you have time to go check it out on the internet, there's a study now called AWARE, which looks at barriers to research participation. If any of you have the opportunity to take a look at that, it's wonderful to have people participate. Anyhow, learning how to describe mental health symptoms in Huntington's. Some of the things to think about if you have a doctor's visit coming up and you or your loved one has been experiencing mental health symptoms, these are the kind of things that doctors are going to ask you or should ask you or will want to know about. How long has it been going on? So you're depressed. Have you been depressed for 10 years? Have you been depressed for a year? Have you been depressed for a couple of years, but it's really much worse in the last 6 months and you think something has to get done now, right? Have there been any recent changes? Did someone else start a medication for something that might have affected your mood? Have you had a recent illness? So maybe you're not feeling well. Maybe you have something like a urinary tract infection that sometimes makes people see things or makes people less motivated. Have you had a recent fall? So one of the things that can happen in Huntington's disease is falls. If you hit your head very hard or even a little bit, depending on what stage of the disease, you can have a bleed into the brain, and that can cause a really sudden change in behavior. So if somebody goes from pretty stable, pretty calm to suddenly very agitated, we do worry about things like a sudden illness, maybe an infection, or a fall that's caused some kind of a change. Are there issues with drugs or alcohol, right? So is somebody hallucinating because they're taking a medication or they're taking a street drug that can cause them to see or hear things perhaps or make them paranoid? And then if somebody's very irritated or agitated, are there things at home that could potentially be dangerous? So are there weapons in the home? Particularly, are there guns? Are there knives? And you need to have a discussion with your physician about securing those so the situation doesn't escalate. One thing to know is that there are some treatment guidelines out there for mental health symptoms that are published. And these were written by myself and a group from the Huntington Study Group and also the European Behavioral Working Group, published back in 2018. So they specifically look at agitation, anxiety, apathy, psychosis, and sleep disorders. The good news is they're completely open access. So if you just Google Huntington behavioral treatment or Huntington depression treatment, anxiety treatment, if you just Google that, these will pop up. And they're completely free. You can download them and take them to your clinician. When we wrote these guidelines, the idea was that they'd be available for non-specialists. So if you were a community neurologist, you might see 1 or 2 people with HD. We wrote them specifically for that. In practice, what we find is that families print these out and take them to their doctors to sort of get the doctors started in thinking about treating these symptoms. They're focused on medication treatment, but they do have some behavioral interventions too. So some of the behavioral strategies I'll talk about today for different symptoms are also outlined in these guidelines. So I'll start out with depression, which is probably the most common symptom as a psychiatrist that I'm asked to treat in Huntington's disease. About 50% of people with HD have depression at some point in the illness. Now, depression is really common in the general population, but it's even more common in people with HD. So we all think of depression as sadness, Sometimes there are other symptoms of depression that we need to think about too. So one of my favorite questions to ask about depression is, are you able to enjoy things? And then someone might say, well, I can't do so much. Well, think of something you can do. So maybe you can't go fishing, but if somebody takes you to the dock and you can watch someone else fish, can you enjoy that? Or do you find that nothing makes you happy, you just can't really get any pleasure from anything? Some people, when they're depressed, become more irritable than sad. Some people have appetite changes, usually decreased, sometimes increased. People may have a sense of life not being worth living. They may be very hopeless, which can be a very dangerous sign in depression. And then HD, of course, is associated with cognitive symptoms, but depression can also make concentration and focus much harder. People with depression often have low energy and sleep changes. So these are some of the other things to think about if you or your loved one is experiencing a low mood. There are some other factors that can contribute to depression in HD. So some things to think about. Has your sleep been disrupted? So do you have so much chorea that you can't sleep at night? And is this part of what's making your mood really low? We have a lot of losses in HD. So has someone recently told your loved one with HD he or she can't drive or work any longer or care for the kids? These are all times when somebody may become depressed. Has a family member with HD died recently, or is it the anniversary of when somebody died? A lot of people do tend to have anniversary reactions in HD. Have you been in a treatment study? So we have these fantastic clinical trials that we heard about today, and these are wonderful. And when you're participating, people pay attention to you, you go into the centers, you meet people, and then suddenly they're over. And you may not even get a result of what drug you were on or whether the trial worked for months and months. So it can be a real letdown, and sometimes it triggers depression in people. And then again, going back to medications. So has someone started a medication that could make you depressed? We have these fantastic medications for treating movements, right? We have deutetrabenazine, we have tetrabenazine, and now we have valbenazine. Terrific for movements, but they do have the possibility of causing low mood or even suicidal thinking. So important to know, has someone started one of these medicines, or has the dose recently gone up? So depression treatment, one of the biggest mistakes I see when people are treated by non-specialists is the dosing. So if you're a relatively healthy person, perhaps you're gene positive, but you don't have a lot of symptoms of HD, sometimes a clinician will put you on a really low dose, like the dose that my grandmother would not even get help from, because they say, well, you've got a brain disease, so you need a low dose. And that's absolutely not the case. So you dose appropriately for the age as long as somebody is relatively healthy. You need to be on a decent dose of an antidepressant, sort of middle or higher range of the recommended dose for it to work. In more advanced cases, if someone is older or very frail, then you may go with the lower doses, or what we call the geriatric doses, but you may still need to increase to a higher dose to get it to work. So underdosing is probably the biggest issue that I see in depression treatment in HD. In terms of the antidepressants that we use, I'm just going to talk about some of the really common ones. And if you're not on something that I recommend, it doesn't mean that your doctor is terrible. It just means that there may be something that's better for you as an individual. The choice of the antidepressant really goes based on side effects. So, does somebody need something that's going to perk up their appetite? Does somebody need something that's going to make them calmer and make them sleep? The response is not always steady. So people sort of get better, then they may not get better for a while, then they may get better again. But it's not always steady, and it's certainly not fast. That's one of the biggest issues we have in psychiatry, that the antidepressant medicines just don't work so quickly. So it can be like a month of taking a medicine every day, maybe having some side effects, and you may not see much of an effect until you've been on it for a while. In terms of the medications that we use commonly for depression, the SSRIs, so the serotonin reuptake inhibitors, are probably the most common ones. And what they do is they stop serotonin from being taken back up to the brain and degraded. So it's not that they're making more serotonin in your brain, they're just keeping the serotonin that you have around and available. And serotonin is one of the neurotransmitters that plays a huge role in regulating mood. So paroxetine, which is Paxil, escitalopram, which is Lexapro, sertraline, which is Zoloft, and then vilazodone, which is Vibrid. Those are some of the really common ones that we use. And usually the doctor will pick them based on how activating or not they are. So paroxetine, escitalopram tend to be much more calming. Sertraline, vilazodone tend to be much more activating. There's also bupropion, which acts more on another chemical, dopamine, and also another one, norepinephrine. It tends to be much more activating. Sometimes it can help with focus and concentration. It will help a little bit with smoking cessation. So if you have somebody who needs treatment for depression, who's also trying to stop smoking, it might be a great option. On the other hand, it can make people irritable sometimes because it's so activating. So this is a case where you have to really pick it based on side effects. Mirtazapine is one that I use a lot. It works on serotonin and norepinephrine, and it's very good for sleep, and it does tend to stimulate appetite and cause weight gain. So it's terrific for people who really need to put on a bit more weight, which is such an issue for so many people with HD. Then there's another class called the serotonin norepinephrine reuptake inhibitors. Again, they're not making more of these neurotransmitters. They're keeping what you have around so that you can use them. Common ones in that class, venlafaxine, which is Effexor, duloxetine, which is Cymbalta, and levomilnacipran, which is Vetsima. So these are some of the other medications that we use. Usually these are more second line, but if you try an SSRI from that first slide and that doesn't work, sometimes your doctor will go to one of these SNRIs. Just a quick word on psychotherapy, because not everything is medication. Psychotherapy can be really helpful, especially in early stages. My recommendation is if someone is early on in the disease or pre-symptomatic and they have depression, it can be very helpful to go for a course of psychotherapy, particularly to learn tools that you can learn later on as the disease progresses. As the disease progresses and cognitive symptoms worsen, it can be harder to learn these tools, but if you learn them early on, they do tend to stay with you. The one I really like is called cognitive behavioral therapy. So cognitive behavioral therapy really focuses on this idea that thoughts are what causes feelings and behaviors, not external things. So if you can master your own thoughts, you can overcome a lot of these negative emotions that you have in yourself. So you learn to catch negative thoughts, label them, and then counteract them. And in HD, a lot of the focus would be on things like being a burden, worrying about future symptoms, isolation. Those are some of the things you focus on. It's a great therapy because it's very short, so it's typically 12 weeks. So you're not committing to months and years of psychotherapy. Just a quick note on suicide. So suicide has been reported to be up to 4 times as high as that in the general population in people with HD. All the usual risk factors are at play. So people who are childless, who are single, who have substance abuse issues, certainly if they own guns, they're all at higher risk of suicide. But people with HD also tend to make very unpredictable attempts and tend to use very high lethality methods. So in my experience, people with HD tend not to just take a paperclip and scratch their arm. They will get in the truck and drive it into a wall. So what's different about suicide in HD? It often isn't related to depressed mood, so sometimes it's more impulsivity. And this is because of the brain changes we see in HD. People have a harder time controlling the impulse to hurt themselves if they have it. Because of higher rates of HD in families, suicide might be viewed as an option. More people have done it, so it becomes more of a sort of normal thing. So we treat very aggressively. Certainly antidepressants would be involved, but often you need to hospitalize somebody who's suicidal to keep them safe until they can really be treated for it. And of course, you want to remove weapons from the home. If you can't remove them, you want to lock them away. A quick word on mania. So this is someone who has an overly good mood. They're overly happy. They might be really fun, but usually they end up becoming more irritable. They make poor decisions, so they might be very grandiose. They have big plans. They think they have very special powers. They tend not to sleep. They tend to spend several days in a row without needing any sleep at all. And they're very impulsive, so they may max out their credit cards, impulsively buy things. Suddenly there's a new RV in the driveway and there's no need for one. may have impulsive sex with people they don't know, so unsafe sex. It's pretty rare in Huntington's, so maybe 5% of people have it. And it can be treated quite well with the medications that we have, the mood stabilizers like valproate, carbamazepine, and also the antipsychotic medications, which I'll talk about a little bit later. So now moving on to anxiety. So again, about 50% of people with HD have anxiety at some point in the illness. Anxiety, as we all know, is that feeling of being overwhelmed, the sense that something bad is going to happen. It often goes along with depression, just like in the general population. People with cognitive decline may have more anxiety. So it may be that they forget things, they can't keep track of things, and this feeds into their anxiety and worry. Sometimes anxiety even develops into panic attacks, where people have sudden heart racing and fast breathing. They may feel like there's crushing pain in their chest and they're dying. They may have a sense of doom. So obviously very important to treat this. Good news is we have lots of treatments for anxiety. They're pretty much the same as what I talked about for depression. So those SSRIs, the serotonin reuptake inhibitors, the SNRIs, serotonin and norepinephrine uptake inhibitors, pretty much the same medications we use for depression. So if you have anxiety and depression going on, you can treat both, which is great. Sometimes someone has such bad panic attacks that they need small doses of medicine like lorazepam or clonazepam, which work on the GABAergic system of the brain. But you do have to be careful with those because some people can get disinhibited with those medications. They can worsen cognitive symptoms, and they can also worsen the fall risk. They sort of have the same effect as having a couple drinks of alcohol. The hard thing about anxiety is that the treatments take longer to work. So remember I said depression, you have to wait at least a month to feel better. Anxiety, it can be 2 months or more of taking a medication and experiencing side effects before you start to feel really better. Also, the dosing usually needs to be a bit higher. So usually the higher end of whatever the approved dose is. So for example, Zoloft, which is sertraline. With depression, I often get away with 100 milligrams. For anxiety, usually I'm pushing it to 150 or 200 milligrams. Sometimes the anxiety is so bad that you need to add some short-term antipsychotics, sometimes some quetiapine or olanzapine, which we try to stop once the anxiety gets better. So now moving on to psychotic disorders. These are not as common. So maybe 10% of people with HD experience psychotic disorders at some point in the illness. Usually they're seen in later stage of the disease, but you can see them across disease stages, including early and pre-symptomatic. Usually it's a false belief, which is a delusion. And I mention this specifically because many of you may see movement disorder neurologists or community neurologists who see lots of Parkinson's. Parkinson's patients tend to have hallucinations. They tend to see or hear things that aren't there. In Huntington's, more commonly, it's a delusion. It might be really hard to know if a delusion is going on if somebody's speech is not good right at the end of the illness. So these are some examples of delusions that some of my patients have had over the years. So the feeling that someone smells bad and no one wants to be around them. The worry that their spouse is having an affair, but it becomes a very serious worry, an obsession almost. I had one woman who thought that her favorite pillow, which was really important to her because she was late stage in the illness, she was in her bed all the time, the pillow was sort of her world. She kept thinking that her pillow was being replaced by another pillow and it wasn't the same pillow, and she'd get incredibly agitated about this. Everyone on the street is staring at me, so people are watching me all the time. Now, as it says in the quote here, sometimes paranoia is just having all the facts. Some of this can be true, right? Perhaps if you have a lot of chorea, people on the street are staring at you. So it's important to really think about whether something is a delusion or is it actually reality and someone's sensitive to it or being affected by it. These are some examples of hallucinations that I've seen in HD. Not nearly as common, but just some examples so you know what I'm talking about. So seeing dead relatives, so seeing your dead mother in the room who's saying negative things to you, hearing angry voices criticizing you and saying that you're a bad person, feeling things, so feeling bugs creeping on your arms, and then smelling strange things. So there's like a chemical smell and it's like someone's trying to kill me with chemicals. The important thing here is that talk therapy, behavioral interventions, antidepressants, they are not going to work. If you have psychotic symptoms, if you have delusions or hallucinations, you're going to need an antipsychotic medication. So the ones that we typically use are olanzapine, quetiapine, risperidine, brexpiprazole. Those are the common ones that I choose for patients. You might need to start with a higher dose and then reduce the dose over time. So our goal is always to use the lowest dose that will help someone, but sometimes if someone is really paranoid and it's really a problem, we need to start with a high dose and then back off over the next few weeks. These medicines all work by blocking dopamine, but they also have some effect on serotonin, particularly the newer ones like aripiprazole and ziprasidone. So they might help mood too. So if somebody is very psychotic and they have horrible delusions and they're also very sad, it might help to bring their mood up a little bit too. I mentioned aripiprazole and ziprasidone second because they're usually not strong enough if someone's really psychotic. So it's kind of a choice based on how serious the symptoms are. There are some older medications, particularly haloperidol, that we might use occasionally if someone's very agitated. And again, this is the kind of situation where we might use it for short term and then switch to one of the newer ones once the symptoms are under better control. So now I'm going on to irritability, which is pretty common in HD. So 30 or 40% of people with HD experience irritability at some point in the illness. So this is reduced control of temper, the feeling of being very annoyed at things. You can be irritable without others knowing it. When I'm irritable, my whole family knows it, so I don't know how this is possible, but someone can walk around feeling irritable without others noticing the behavior. It's always unpleasant, so people don't wake up in the morning and feel really happy that they're irritable. It's a terrible feeling. And often in HD, people have irritability with poor insight. So they feel like everyone else in the family is picking on them. My wife is on my case all day. And that's actually the person themselves experiencing irritability. So irritability's ugly sister, as I like to say, is aggression. So that's when it goes from being this internal feeling of being annoyed to actually acting on it and causing harm. So aggression is when you have behavior that wants to hurt someone else or something else. It's hostile, it's attacking. I say it this way because it's really important, particularly if you're helping someone or you have somebody in long-term care who's agitated or just has a lot of chorea. Sometimes helpers will misinterpret this as aggression, right? They'll say, he tries to hit me when I'm changing his shirt. No, maybe he just gets more chorea because he gets a little bit, anxious when you're changing his shirt. But sometimes it is obvious. The person has a closed fist and they're really going after you when you're trying to help them. It can be verbal, so it can be threats. I'm going to kill you if you come over here. It can be harm to pets, so throwing the cat across the room. It can be property damage, putting your fist through the drywall, or harm to other people. So how do we treat these things? So I'm going to do irritability and aggression together. If it's more irritability and it's not impacting others terribly, or if it's mild aggression, like someone threatens to hurt people but they never act on it, then you probably have some time and then you'd probably pick one of those antidepressants I mentioned. You'd probably pick a more sedating one because you want to calm things down. So you might do the Lexapro or you might do the Paxil. Usually we end up going to an antipsychotic. And again, we're going to pick one of the more sedating ones. So we're going to do olanzapine or quetiapine. Not that the person has delusions or hallucinations, they're very agitated. And these drugs, because they block dopamine, tend to calm that down. We also have drugs called mood stabilizers like valproate, which is Depakote, which acts on the GABAergic system of the brain, which can be very helpful with this. There are some cases where benzodiazepines, so those Valium-type medicines that I mentioned, can be really helpful. The common ones that we use are clonazepam and lorazepam, but the big note here is that, again, these medicines can cause disinhibition. So if you think about people who drink and you think about the person who drinks and has a couple drinks and becomes a happy drunk, or you think about the person who has a couple drinks and becomes the angry, nasty drunk, right, who wants to fight everybody in the bar. So that's the problem with some of these medications with some people, that if someone's really agitated and you're trying to get them to calm down and you offer them medicine, for some people it will have a nice calming effect. For other people, it will just make them really angry and more disinhibited. So now I'm just going to talk for a minute about apathy. So this is when someone has poor motivation and can't get started on things. They have decreased goal behavior, so they don't plan things. They're not thinking about what should happen in the future. And they don't have a lot of emotion. So, something really great just happened. Their daughter just had her first baby, and they don't seem to be interested. This is really common. We think, 80% of people will have this by the end stages of HD. It tends to start early in the disease and just gradually get worse over time. So once someone has it, they're pretty much going to have it throughout the course of the disease. Treatment of apathy is hard. So unlike all these other things, I don't have psychiatric medications that I recommend typically. Sometimes if it's early in the disease, particularly if it's someone who's working but has trouble being motivated, has trouble focusing on tasks, I might start a stimulant medication like Ritalin, which is methylphenidate, or I might use bupropion, that antidepressant, which is Wellbutrin that I mentioned before, which is very activating and sometimes does help with focus. There was a study that was done in Europe on Wellbutrin, bupropion, that found that it does not help apathy, but it was a great antidepressant. So sometimes I'll try it just to see, and if someone has a little depression with their apathy, then maybe it will work. It is a difficult question sometimes as to whether somebody's apathetic and they have poor motivation, or they're depressed, which can also make people look very apathetic. That's where that question I said about, can you enjoy things comes in. Apathetic people generally don't care. They're not suffering. I hate to say it that way, but the apathy makes it so that it's not hard for them. It's hard for the family to see somebody who's not, finding joy in life and not reacting to things. But the person with apathy generally doesn't care. Whereas the person with depression is sad and they can't enjoy things and it causes them suffering. One note about apathy is that sometimes stopping medications will help apathy more than adding medications. So particularly the SSRI antidepressants can sometimes make apathy worse. If someone's been on an antidepressant for years and years, and we all have, all probably have family members like this, they've been on Zoloft for 10 years, perhaps you could try at least lowering the dose or maybe even stopping it to see if the apathy gets any better. At worst, maybe you'll just find out they don't need to take it anymore, right? So minimizing medications is always a good thing. The other part to keep in mind is that sometimes someone is apathetic most of the time, but every now and then they're irritable and aggressive. So they're a bump on the couch all day, they don't do much, unless you ask them to change their shirt, and then suddenly they're screaming and tearing up the house. If you try to treat apathy, sometimes you will make that irritability and aggression come out more often. So that is one thing to know. So how do you treat apathy? So the best things to do are behavioral interventions here. So offering yes or no choices. So you don't hand someone a 5-page menu at a restaurant. You just say, oh, they have shrimp and steak. Which one do you like? Structured activities. So you go through one step, then the next step, then the next step, rather than just giving somebody a list of things to do. Doing the activity with someone, which as a caregiver, of course, is not efficient, but getting involved, unloading the dishwasher together, putting away laundry together is one way that you can keep someone engaged and get them to do more. And then think about the environment. So apathy is kind of funny because for some people, as you might expect, the environment is boring. There's not a lot going on. They're inside with the shades pulled all day. Maybe they need a little more going on. For other people with apathy, it's too much. Right, so there's a TV in one corner, there are little dogs circling around there, and there's a grandkid over there, and it's just too much. So you need to calm the environment down, and then the person will actually engage and do more. So you kind of have to try it out depending on your person. Okay, so quick note for care partners. How many of you got on an airplane to come here? Yeah, so we all heard this announcement about you put on your oxygen mask, you put on your own mask first, and then you help the person next to you who needs help. We all ignored it. We say this to care partners all the time, and you all ignore it, but you can't, right? So you have to take care of yourself, because no one else is going to take care of you. You're the caregiver, right? So if you are suffering from any of these mental health symptoms, particularly depression and anxiety are the big ones I see, sleep issues, if you're a care partner, please think about asking your PCP for one of these medications or for a referral to a psychiatrist. Really, really important. HDSA has wonderful resources for care partners. So please, check with your chapter, check with your center social worker. They have great resources out there so that you don't feel alone and you can learn about how others cope with this. And one more plug for cognitive behavioral therapy. So care partners are busy. They don't have time to go for weeks and weeks of therapy. Again, this is a 12-week therapy. It's available pretty commonly in most places. And you can really work on some of the negative feelings that you have as a care partner. So feelings of resentment, feeling overwhelmed, all the things that come up when you're taking care of someone with a chronic illness can really help you to cope better with this. So please think about it. So in summary, I hope I've shown you that these symptoms are a major part of the disease, even by people's own report, the most important thing that bothers them in HD. I've given you a little bit of guidance. We've got those guidelines out there from the Journal of HD. They're open access. You can print them out and take them to your doctor if you feel he or she needs a little help getting started with medication treatment. Think about environmental factors. So are there things that you can modify, particularly with apathy, to make things better for your person? And then treatment can reduce the burden. Not only treatment for patients, but for caregivers can reduce the burden of HD overall with these mental health symptoms. And then I have one final note. So CHDI asked me to mention that the HD RAC study is going on. They have 175 people who've done it, but if you haven't had the opportunity, they have some booths set up right outside this room going around the corner, and they will be happy to talk to you about that study. It's all online, and you can do it right here. It'll be open for the next couple of hours. Thank you so much.
What recommendations do you have for a care partner or a family member in helping the person with HD get treatment or psychiatric treatment or getting to that type of clinic if they need it?
So one of the common things we find is that people with HD may not have a lot of insight, right? They may not realize that they have a mental health symptom, so they may not want to go to clinic for that. If there's something else that you can use as a hook to get them into clinic, maybe they would like to talk about falls, maybe they want to talk about research and they're really excited about a new study. If they have a relationship with the clinic, just saying, oh, you haven't seen your doctor for a while, she's really excited to have you come in, sometimes that will work. And then if you have a chance to call the clinic ahead of time and give them a heads up and say, we're coming in and he's going to say that we're here for movements, but really we need to talk about the irritability and aggression. Those are some of the tricks that I've seen families use pretty well over time. So those are some of the ways that we can try to get people in. But it's very hard if somebody doesn't have a lot of insight and they don't like to come into clinic. And a lot of people don't like to come into clinic. The other solution I've used is telehealth visits. So sometimes people will more readily hop on a telehealth visit with me than they will come into clinic. And you may be able to get somebody to engage through that since they don't have to leave the house. Yeah. Thank you. Thank you very much.
I have a question about and a comment. I have used our local police who've been trained in crisis counseling, and I set up an appointment with them to come like 2 hours before. So wake up my son, tell him he better get down to Columbus because of this 2-hour drive because of medicines are so important. Something about the uniform triggers a different reaction with them.
Absolutely. So if you have law enforcement, especially if they've had HD training, I hate to frame it this way, but sometimes if you have a large male relative who seems to be very authoritative, who can just come in and say, you're going to clinic and that's it, and we're not going to argue about it today because you have to go, sometimes that will do it. So whoever's sort of an authority figure in the person's life that they'll listen to, absolutely.
And then the other comment was, I really am discouraged with using emergency rooms when we have crazy behavior. And if anybody can find their own freestanding outpatient mental health, I did find one in Florida and it really did keep my daughter out of the institution.
That's a terrific point. We try very hard to keep people out of the emergency room. Sometimes you just have no option, particularly if someone's suicidal or if they're very violent and it seems like they're going to hurt themselves or someone else. But everything we can do, including increasing medications over the phone rather than doing a clinic visit, everything we can do to keep people out of the emergency room, because the emergency rooms are not set up to deal with rare diseases and they often struggle.
How do you work someone through the paranoia of side effects from the medications that are an option?
Yeah, that's hard because with all the, it's wonderful that we have all these medicines, we have all this information available online now, so people can read as much as the doctors have, right, about, medication side effects and who experiences what. I try very hard to give a reasonable and balanced accounting of what the side effects are. I stress to them that I've been treating people with HD for 25 years, and I've used these medications for, in some cases, 25 years. When you look at all these side effects, this is what's common, this is what's not so common. Sometimes if you have the time to do it, if it's not someone who's really agitated and potentially really violent, starting with really tiny doses, and reassuring them that, this is the tiniest dose that we could possibly use. So, if you want to try this tiny dose, I don't think you'll have a side effect, and then sort of edging up very, very gradually. But it is really challenging when somebody's paranoid and they're online and they're well read about side effects. It can be very challenging to get them to try a medication. I agree.
Questions?
On some of the Facebook support groups, people are using the THC products, the marijuana, and thinking, I'm not going to do drugs, but they'll do that. And I really always answer, this is a drug too. You're just picking one that's still affecting your brain.
Right, THC, marijuana products, they can be a little bit unpredictable depending on the source. Varies state to state as to whether they're legal or not. Some people use them and they do find them beneficial, but I don't have recommendations. I think we don't know enough about them in HD yet. And so it's hard to make a recommendation. And I ask people to first try the drugs that we've tested over the years that have FDA approval.
All right. Well, thank you, Dr. Anderson. It's been very, very informative. So we really appreciate you being here with us today.